Welcome to Heartline, conversations with healthcare changemakers following their Heartline. I'm your host, Dr. Andrea Austin. I'm an emergency medicine physician, coach, and educator. I believe that healthcare needs to improve the quality care that patients receive and that supporting the workers is at the heart of this transformation. I am so excited today to have Dr. Purdy on the podcast. She has a title that I didn't even know existed until a few years ago. She is both an emergency physician and an applied anthropologist, and the lens at which she sees healthcare is truly unique, and I'm so excited to have you on the podcast.
Thanks for having me, Andrea. Thrilled to be here.
I'd like to start with our question about how did you get to be an emergency physician and applied anthropologist and also simulation educator?
Yeah, I guess all of these kind of identities are fairly interwoven, really. I went to medical school and ended up training in emergency medicine. But kind of at the same time that I started my training in emergency medicine, I just became fascinated by the different organizational kind of cultures that exist in healthcare. So as a part of our training, we really rotate around the hospital. And in your kind of final years of medical school and first years of residency, you really become a kind of cultural chameleon around the hospital. And I started to notice that certain teams that I was working in had occasionally very different values and beliefs and practices than other teams that I worked in. And oftentimes this led to quite a degree of high function in healthcare, but it was also oftentimes the source of conflict between teams. So I really was pretty interested in how these different organizational cultures either facilitate the provision of excellent care or how they sometimes get in the way of people performing at their best. So partway through residency, I decided to start doing a little bit more research and training specifically about culture. And I stumbled across a master's program that really took people from all different industries, so healthcare, education, government, business, and gave you some skills and perspectives in anthropology to take back to whatever workplace you were a part of, because anthropologists recognize that culture is it's relevant to everything that we do in every workplace that exists. So I ended up doing my master's thesis in the culture of trauma care here at the Gold Coast Hospital and Health Service. And we really did a deep dive into how the organizational culture of the trauma service here kind of shapes and impacts care, and how we can continue to shape that in a direction that is best for providers, but perhaps most importantly, best for patients.
That is so fascinating. So you went and got your master's during a period of time. I know the terms are different between Australia and America, but essentially during residency.
Yeah, I did my training in Canada, so very similar to the American system. So yeah, during my residency, kind of my second to fifth years in residency, I did my master's alongside my emergency medicine training, which meant that I actually was kind of, I think, developing these dual identities at about the same time. And really, I found that my background in emergency medicine gave me some unique kind of understanding as an anthropologist, also access to a group of people that it is traditionally really hard for anthropologists to embed with. And as an emergency physician, my background in anthropology just shapes everything that I do every day, really.
Yeah, I think that's something we need to consider more in the US because it's pretty unusual. Most of the time, if somebody is able to work in a master's into residency, it's business related. Like some places have like an MBA, some places have an MPH. But I think there's a lot to this, having more of this. I mean, anthropology is not, I guess you can study it in the liberal arts, but something that gives people like a broader understanding of the humanity of what we're doing and how we practice.
Yeah, certainly. And I guess I have to have a shout out to my residency program, who just afforded me a degree of flexibility to make this work and make this happen. And when I went to them with this as an idea, I got nothing but, wow, won't that be kind of a real advantage for our field of emergency physicians to get a different outside type of knowledge and what can we do to help you make this happen instead of putting up any type of barriers. I guess one of the advantages, though, that we have in training, and I see this even more in Australia, but in Canada, our emergency medicine training is just a bit longer than it is in the States. And so there is just some more time for a bit more flexibility, probably to get some niche experience in certain areas.
So I'm working on a qualitative research project right now, and I have to get a bit into the weeds into like how you were able to do your research, because when I've read about anthropologists, oftentimes they're living with, they're very closely, like you said, embedded in the culture, the experience. So did you have to consent, like the teams that you were on, or like how did that work?
Yeah, I guess I was fairly well positioned when I came here in 2018. So I didn't work here ever before. So I was coming down and I worked a quarter time clinically. And then the rest of the time I was doing this research. And I guess at the end of the day, it ended up being kind of a true participant observation in that I was embedded in this group that I was working with. None of the kind of direct observations that I took were from when I was working my clinical shifts. But I did have time as an observer of the trauma teams, both in their training and in their practice. And it is interesting from an ethics perspective. It was a real challenge to work with fairly kind of scientifically positivist-minded ethics review boards to guide them through how this could be an ethical undertaking, and in fact, not undertaking it would be unethical. So essentially to the 500 trauma care providers that work at the Gold Coast, they got information about the project. They got information that observation would be happening. And at the beginning of each month, I would send out the days that I would be observing. And if people wanted to opt out, then they could contact their line manager, and then I would just move to another day. That happened 0 times. Like it ends up being a non-issue because most people don't actually have a problem with it. During those observation periods, I would do some informal interviews with people and just take notes based on those. So those weren't recorded. But then I did a series of formal interviews and then a series of kind of questionnaires and some qualitative studies that people provided consent for when they did the survey. So a layered consent process. And I guess one of the things that anthropologists think of, again, a bit differently than traditional scientists, is that ethics is an ongoing process. It's an active process as opposed to something you do at the beginning of the project to get a tick box kind of completed. So every day that you show up to work, you're telling the people there that you're doing this research and that you want their perspectives. And it's a thing that you're kind of actively engaged in. And I guess one of the real reckonings that anthropologists have had is they've got a bit of a dark history in kind of colonialism. And so figuring out how projects can be ethical is also largely rooted in their design. So a lot of anthropologists now really want their projects to be designed by and with the communities that they're working with, as opposed to doing research on something. So the project that I did here was really co-designed with leaders in trauma care. And this was a project that the group was doing, not something that I was doing to the group, if that makes sense.
Totally makes sense. And that's led me to wonder if, I know we've had conversations about this in the past, or I've seen you talk about it. One of the challenges that we have in medicine is the way we talk to each other. And I was going in for a shift last night. I actually recorded a pod with somebody else right beforehand, Dr. Josh Hartzell, about leadership. And I said, I'm fairly certain I'm going to go into my shift today and get yelled at some point by a consultant that's angry about calling for an admission or whatever it will be. And I'm wondering if the lens of being an anthropologist, if it ever softens that blow, because you understand that some of those behaviors were essentially cultivated, or it was almost like a rite of passage that they had to do some of those behaviors to be tough. This is just my musings listening to you talk about anthropology.
To be honest, I thought it would be protective. It mostly makes me a lot more sad than I think a lot of my other colleagues, because I think it's easier to brush off when you maybe don't understand just how problematic it is. So, if you can say whatever, the surgeon swore at me or told me I was useless. But I think the research that I do in team science and what I understand about culture is just how damaging that is for patients and just how accepting we are of it as a profession and as an organization. And I think as an anthropologist, you have a bit of insight into just how much it takes to change all that. And so I think I understand it, but I'm not sure that's protective. It might make me a bit of a nihilist and a bit of gravely concerned about the future of our profession.
Yeah, well, I'm right there with you. I am greatly concerned. So now I'm curious, where did simulation enter the story? Because the reason I invited you on today is I'm a simulation educator and administrator at this point, and I think simulation is one of the beacons of light for us, maybe changing culture, this endeavor to change. And so I'm really curious at what point simulation entered the story.
I guess I am in some ways just a child of simulation. So all of my residency training, I was engaged as a participant in simulation, but it all crystallized for me when I came and I did my thesis for my master's here on the Gold Coast. And while we were studying this trauma team and this trauma service, it became really apparent that there was this monthly event that, as an anthropologist, I describe as a cornerstone ritual for this service. And it was a monthly simulation that brought together everybody who's involved in the provision of trauma care. So anesthetists, surgeons, ED nurses, ED doctors, radiologists. And once a month, they would do a simulation of some type of case. And some people learned a little bit about chest trauma, or you might learn a little bit about how we're going to do this difficult intubation. But when I spoke to people in the ethnography that I was doing and tried to understand the impact of this monthly simulation, people said things like, I learned other people's names. I learned that we can trust each other. I learned that I'll get help from my colleagues. So some really kind of higher level things that get at underlying values and beliefs rather than kind of the transactional nature of knowledge that we often think of for education. So this was a real moment when I thought, wow, this actually is a time when we are shaping culture, because it's kind of this moment of cultural compression, this time when values and beliefs are particularly on show, and they're probably transferred with a higher degree of intensity than maybe in just our daily work. So it's a time when we actually get to really shape what are the values and beliefs that are important, and we get to lead conversations that highlight exactly kind of where we want to go. That was my entree into simulation. That's why I kind of found it particularly interesting. And this was a real evidence of probably simulation that was quite positively shaping culture and helping a team move in a direction that was useful for them. But I guess we see examples of the opposite as well. So we see sometimes if simulation perpetuates some blame or shame, then that might have the kind of opposite and negative impacts as well. So there's real potential and opportunity, but also a lot of risk and a lot of responsibility in the people that are leading these types of activities to get it right. And so I've spent certainly the last few years thinking about how we do that and what that might look like in different teams.
Yeah, there's so much there. I love the way that you crystallize that. And one of the things I'm getting asked a lot is, well, show me the benefit of simulation. I want the return on investment with financial dollars behind it. And there's growing translational data. But what I've been trying to explain to people is that, what is the price on that? It's hard for me to show you how. I posted on it yesterday and I linked to your paper that I had this moment in the sim lab with our respiratory therapists and nurses and my sim manager and me. And we all of a sudden clicked why a piece of equipment was not being used and why it started off like everyone should be using that. And there wasn't curiosity around like why it wasn't being used. It was like, send out a reminder, everyone use this. And then around this sim mannequin and listening and actually trying out how the piece of equipment fit in and then where does it come from, we uncovered a whole lot of issues around it. But it was the feeling in the room, that the look on people's faces, that everyone was listening and sharing information. And that's what I'm trying to show. But it's hard. I don't know. Do you have like more ways to make that argument to the C-suite?
Yeah, it's funny. So there's lots of ways to measure impact. And I think that's where some theories can be really helpful. So we have used relational coordination theory, which comes from the business world, about how teams coordinate complex and interdependent and kind of time critical work. Theories related to psychological safety can also help us kind of measure, I guess, some important things that maybe just seem like they're below the surface. But we honestly have found that the most powerful things is talking to teams and hearing just that. So when we, again, work with a team over a long period of time and say, what has this done for you? And they say, oh, it's allowed us to build trust. It makes me more excited to show up to work. These are exactly the type of things that actually kind of C-suite level people are interested in, right? Like culture is this buzzword in organizations, and there's no kind of specific ways that we're shaping it other than just talking about culture. But if you, as the translational simulation person, can come in and say, hey, look, I've worked with this team. They've identified ways that they want to improve. And over the last 6 or 12 or 18 months, they actually feel like we've gotten there. I think those stories and those kind of participant experiences are really helpful. Every once in a while, you get a bit lucky with things. So we've worked with one of our maternity teams here, again, using relational coordination theory as a kind of guiding theory to help over an 18-month period with their response to postpartum hemorrhage. And it turns out postpartum hemorrhage is actually a thing that you can measure pretty well, and it's already being measured all the time. And over the period of time that we worked with them, their rates of severe postpartum hemorrhage decreased by half. And so when you think about what that means at a hospital level in terms of time spent in hospital, blood transfusions, transfers to theater, all of a sudden you can probably tack on some dollar signs that are starting to be of interest to people. Whether that had to do with our simulations entirely is hard to know. But I think looking for things that can demonstrate value in ways that people are attracted to is fine. We know there's a lot underneath all of that that also had impact and is probably actually even more important than this little number, but people like numbers. So occasionally you can find the ways to improve things in a really easily measured way. But we have also kind of committed to spending time trying to uncover what actually are these, what people often think immeasurable things like relationships and values and beliefs and culture. So you could just hire an anthropologist.
Yeah. I would love that. You want to move to California, Eve?
Sounds pretty good.
Maybe we can just swap. That would be fun too. Just swap jobs for 6 months.
It's an interesting thing. We're talking about this a little bit, that when it comes to thinking about simulations impact in a health service, or there's all of these different conceptual foundations that can be valuable. So you could think about having a systems engineer or an anthropologist or an organizational psychologist or a health economist, but you probably can't have all of those things. So a part of it, I think, is sorting out what your simulation teams and services goals are. We're kind of unashamedly trying to shape culture around the hospital. And that really is one of our kind of core principles. And we have the skills and the people and the kind of faculty development that goes along with that. But just as easily, we could say, look, actually, our most important thing is going to be testing new clinical spaces. And then we might actually think about getting an architect on our team, or the kind of specific skills needed for whatever aspect of healthcare you think simulation is going to help your health service with the most. So we happen to be using culture as our lens a lot of the time, but there's other ways. There's certainly other ways to do it.
Yeah, I love that, because what you're really saying is it's hard to do it all. To take a step back, and what is the mission and vision of your simulation center, and build the team around that.
Yeah, exactly. So what is the purpose really first? And one of Victoria Brazel's favorite sayings that I think is really relevant to this is, you can do anything, but you can't do everything.
Yeah, absolutely. And I think I've been immersed in simulation for quite a while. And sometimes I forget that the uptake, especially in community hospitals that aren't traditionally academic, is pretty abysmal in the United States. So I forget that I'm having conversations with people that have never really interacted with simulation in any meaningful way. So the place that we're starting these conversations at are really different. So maybe I can pick your brain on that a little bit. When you're introducing the concept of medical simulation to people that haven't really seen it or heard it before, some people will use the flight simulator analogy. Well, it's kind of like pilots going into a flight simulator. And some people get really upset when you use that analogy for medical simulation. How would you explain it to someone that doesn't really know much about it?
Again, I guess it would depend a little bit what the purpose is for. So when we think about most of my work is with healthcare teams and how we can help healthcare teams improve. And the simple analogy is we come together as a healthcare team to provide what we hope is high quality care. And other teams that provide high quality care have a time and space to practice together. So why do we expect different than for our healthcare teams? So a high performing sports team has the opportunity to come together and practice. And so creating space for teams to practice, to learn how to have conversations, to think about how they might do their work better. It's a no-brainer. And I guess one of the other ways to think about it would be, could you imagine if our patients knew that we weren't actually thinking about our work together? I think that would just be shocking to patients that we largely don't necessarily create the space to do it. So in some ways I think sports teams analogies are helpful. One of the risks there is that our teams are very different than sports teams. So we're more healthcare, even though we like to think of ourselves as kind of high performance. We really are much more like kind of pick up basketball teams that just come to a court and throw a ball around and play together without the opportunity to practice and improve. So how do we move ourselves from this kind of pick up basketball team to a team that's higher performing, and probably is one of the gaps there.
Yeah, it's actually pretty shocking when you look at how infrequent practicing as a team is. And then the other piece of that, I think healthcare largely assumes that the people that show up on the team are individually ready. But if you look at like competency data, the studies that have been done, competency, depending on the procedure, falls off pretty quickly. I mean, it depends on a lot of different things, but you can use 3 months for most people for central lines as a general rule. If you haven't done a central line in 3 months, there might be some issues around that. So we don't really have ways, at least in the United States, to ensure everybody would have access to practice putting in a central line. And then 2, during those high stakes situations in which it might be time sensitive, we don't practice as a team. I think all of us have been in a situation where you're asking for a piece of equipment and somebody doesn't know where it's at. It could be simulated very easily.
Yeah. And I guess it's a little bit tricky because, especially in emergency medicine, where our job is so unpredictable, kind of simulating specific events, I think, is almost less the goal. And it's more, how do we simulate how we're going to have the conversation about how capable we are at this, right? Like, I would way rather a team, ideally everybody would come competent at everything, but I'd much rather a team that can negotiate that together, that can maybe engage in some backup behaviors. Let's say there's a resident that's putting in a central line that's obviously struggling. How cool would it be if the nurse that's been in the ED for 20 years can help out and knows that that's expected and knows that that would be wanted and knows that that's actually part of his responsibility is to help this resident who's struggling. So I think one of the unfortunate parts about healthcare is we are often fixated on individual competence when really we know that the only thing that gets our patients through their hospital stay is how well or not our teams are able to coordinate their work. And underpinning that is a lot about values and beliefs and trust and familiarity. And so we have found that simulation is a place where maybe we can look at competence a little bit, but probably where the money's at is focusing on these things that can help our teams regardless of who shows up on the day, and may end up having a kind of broader impact, because you can imagine the amount of money that it would take to keep everybody competent in central lines if they have to be doing central line courses every 3 months. Like, it's just a non-starter. But if we can be confident that our team on the day will arrive and be honest with each other about the last time they put in a central line and that they might need a little bit of help doing that, all of a sudden I think our outcomes for our patients will probably be better, because we probably can't just continuously target all of these individual skills as much as we would like to. It's probably not feasible.
So this is why I love having the podcast, because I think you just solved a lot of the problems that I have. I think we can look at competency for residents for sure. They need to make sure that they can do the right number of procedures. Then most days are supervised and checklists. That's great. But after residency, you're going to be assumed to be competent for the most part. So it's really these, I guess, are called non-technical skills. Do you have a better word yet? I think you and Victoria and I have discussed this before. Soft skills, non-technical.
Critical skills. I don't know. I guess the specificity around those skills is probably the most useful. So thinking about specific leadership behaviors that are useful, communication strategies that are useful, some affective natures that are useful for teams, some specific teamwork behaviors. So things like, can you give feedback? Can you actually facilitate some introductions of your team? So yeah, definitely a whole host of skills that probably, while you have to come and be competent, that's actually not enough. So even something as simple as a central line, which seems like an individual skill, it's not really when you think about it. Like, I'm picturing in my mind the last central line that I put in, and there was a whole bunch of people making that go well that were not just me. In fact, it might have been in spite of me.
Yeah, I always say I'd rather have the physician that maybe would get a B on their technical skills, but would get an A+ on their teamwork, communication, and leadership skills, because that in these difficult situations is what really ends up getting the patient through. I mean, sometimes it's an amazing, I think we laud like, oh, I got that airway and it was so hard. And because I had all this expertise and I knew how to flip the bougie this one specific way, it saved the day. And that's rarely the case.
Yeah. And it's not to say that the individual technical skills aren't important, because they are. But I think if we're thinking about something like an expensive intervention like simulation, and especially if we're getting authentic teams together, we really need to be going to the next level. Because even if we think about a resus room, we need to be thinking about what is the responsibility for everybody in that room to be maintaining situational awareness and engaging in backup behavior and adapting and flexing within their roles. We spent, one of the risks, certainly in Canadian and I think American simulation, is we spend a lot of time focusing on the leader, and the leader has to do all these things. That's certainly how ATLS and ACLS run. But what about the other people on the team and their roles and their responsibility for the teamwork as well? One of the advantages of spending time with teams over a longitudinal period is you get much further below the surface. A lot of teams that we start with, all they can say is closed loop communication, like that was it. Even though nobody closed the loop, because we don't do that in most of our job most of the time, because it's not really the way that we should be communicating about most things. But if you spend some time with teams over a longer period of time, you actually get to have much more nuanced conversations. Like, did we have the right amount of explicit communication and implicit communication? Did we get that balance right? Did we do recaps at the right time? Did we actually get what we needed out of those recaps? How can we support the leader in making a recap happen? And how did our team adapt and flex? How did we know we needed to do that? What are the signs that we pick up on in our colleagues when they're stressed? And what is our response to that? So I think really there's all of these opportunities to go deeper with teams, and doing that over a longitudinal period of time is probably easier than in a one-off random simulation conversation.
So again, I want to pick your brain on a problem we've had recently. I love the analogy of the pickup basketball. I think Dan Dorcas, who you know, introduced me to the term swarm teams. So when you have these swarm teams descend on an emergency somewhere in the hospital, and the team that arrives is, quote, the experts, that are more skilled, more knowledge, whatever, to handle the situation. And they've been asked to come, but something was already in progress. There were some first responders in the hospital. Now the swarm team is trying to take over certain roles. And some people do this with more skill, more ease, smoothness, and other people don't. And it's come up to an issue now where it's beyond hurt feelings. It's now affecting like culture. And I've suggested that we need some scripting around how we take over those roles, but that's tricky. So I'm wondering in all your research if there's some verbiage that has come out on how to do that more. I mean, you got to do it quickly, an emergency, but what language would you recommend, or what do you do when you arrive in these situations?
There's probably a bit about language that can be helpful, but I guess one of the more critical parts to understanding a problem like this, so these are exactly the types of things that teams come to us with. There's this thing that's causing an issue and now everybody's upset because the Met call team came and made everybody feel bad, or things didn't go as smoothly as you wanted. And I guess just taking a step back and diagnosing the problem is really important, because I think there's a fundamental kind of piece underlying this, which is really important to sort out, which is, what is the stance of these teams going into these rooms? And is their stance actually, we're here to help. Thank you for getting us this far. We recognize your job is hard and we have the luxury of showing up and with more resources and skills, and we want to help you. So is their stance actually of help, or is their stance actually that they're superior and cooler and better? And so I think sorting out if this is just a skill problem, which is the language and scripting that you talk about, or is this actually a fundamental problem in the way that these two groups of people see each other? Because those issues require kind of different responses and require different strategies to solve. So if this is actually the Met call team that's coming, or the emergency response team that's coming to help out, they actually really want to help, and you talk to them and they say, yeah, we actually feel like this is going a bit awkwardly too. We also feel like maybe there's a bit of animosity, but we don't want that. And we know that people are trying their best and we really want to help. Now, all of a sudden for that group, some specific language skills might be really helpful. But if you talk to this group and say, oh yeah, people are idiots around the hospital and we always show up to these total disasters, and like, I just wish they'd get out of the way. Ooh, now we're actually dealing with a different problem that language isn't going to fix. It might be a part of fixing it, but there's probably some more fundamental issues related to mutual respect that we need to dive into. So I usually try to just take one step back and say, is there something underlying this behavior problem that we need to get at and understand?
I love that. And it's probably a mixed bag. I'm curious, when you run into teams that it is the second one, which unfortunately is the thornier, harder problem, does simulation help? I mean, some of this is like being a good human. And it was funny. We had a team meeting yesterday and we're discussing sims for the upcoming year. And it's essentially like, do we need a course on some basic communication practices? And I said to my manager, in some ways, I felt like I was more skilled at this before I went into medicine, but then the culture is so crazy that I'm like having to relearn it sometimes. Certainly, when I came back from deployment, there's just sometimes I've just had to relearn some of these basic things. So when you diagnose, I guess, dysfunction and maybe some high level dysfunction, is it a course that you put people through, or is it just through simulations you think they can learn to start softening on that?
It probably depends. And oftentimes, though, interventions that are needed in that type of situation are really multifactorial. Like there's not going to be one thing that magically changes this. And unfortunately, it will be slow. So there's not going to be an immediate fix. But one of the things that we have found most powerful is actually uncovering that for teams and groups, uncovering it, presenting it back to them and saying, what are we going to do about this? We all have the interest in these patients getting the best care, and this is getting in the way of it. So what are we going to do about it? And there's any number of things. It might be that maybe there's a systems problem in this hospital where this Met call team is being deployed too often. Like maybe the sensitivity is too high. And so maybe they're overwhelmed because they're showing up at a lot of non-emergencies. Maybe we do actually need to fix something in the system to make it so that this team is showing up at the highest priority, kind of most relevant calls. Maybe there is actually just a lot of time away from the hot zone. So one of the challenges of these kind of swarm teams is that they come together. They rarely have the time to actually talk with each other after the fact because everybody goes in a different direction. So maybe we don't actually need simulation. Maybe what we need to do is have a commitment that before anybody goes anywhere or an hour afterwards, that we're going to have a 5-minute conversation about what went well and what could have gone better. So maybe actually clinical event debriefing is the best way to get at improving our communication and understanding of the situation. Maybe simulation is a good answer. And oftentimes we find that this is a good place because it's away from the hot zone of an actual clinical encounter to just spend some time together. But I think it requires making the explicit objective related to this simulation program that I, again, would say needs to be longitudinal. This isn't just a course that people come to and that's the end of it. This would be with the explicit objective of saying, look, one of our objectives is to increase the knowledge of each other's roles and realities, is to explore each other's performance and to understand and maybe optimize the handover process. Like maybe that can become the nexus of these simulations, which is we recognize that this actual moment is a moment of conflict. How can we make it better? What would be good for the teams that are doing the handing over? What would be the teams better for the teams that are receiving the handover? And how are we going to optimize this as a group? So that might give them something to focus on, but underneath that, they'll start to have lots of kind of important and respectful conversations. And then depending on what you find as well, it may be that this is a great opportunity for some specific leadership coaching and observation. And maybe actually if there's particular personalities that are really problematic, those people just need some real feedback and actually need somebody to observe their performance and provide them with some degree of coaching. So unfortunately, really not one single fix here.
Oh, are you saying that we don't work in a simple, straightforward environment with simple prescription?
Yeah, it's true. We don't. There's probably one simple prescription, though, which is that if there is somebody who repeatedly behaves badly, despite getting feedback and is ruining teams, they should probably just be fired. But
Ooh, I love that. Accountability. Because I think
accountability, but like these people ruin teams and they're dangerous for patients. And most of us know who they are. And we don't do a lot historically in healthcare to manage their performance. And if their performance can't be improved and shaped, and if they don't actually share this fundamental value of teamwork being important, then they just can't participate because they're ruining their teams. So that's a bit of a hard line, but unfortunately, we have accepted a lot of really poor leadership behavior in healthcare, and it kills patients.
I couldn't agree with you more. I'm actually working on an article right now. I think I'm going to title it Leadership Malpractice. And I truly feel that the lack of 360 evaluations is completely unacceptable at this point. And I think every medical director that I've worked for has not had a 360. And I'm like, how is that? And some have been horrendous. They have done terrible things to people. And I'm like, how have they not had a 360 evaluation? Because some of it would have come out. I mean, probably not everything, but some of it would have 100% come out.
Yeah, but it comes back a little bit to what we were talking about earlier, which is we've really prioritized a lot of kind of scientific and positivist thinking in healthcare, which is, but they're a great clinician. And unfortunately, our knowledge about team science has evolved to show us that's just not enough. And if you don't also bring these other things like respecting your colleagues, being problem-solving oriented, having some understanding of how other people work, and being committed to the team's shared goals, then you just aren't, in our modern healthcare environment, you're just not doing good enough. And I guess reorienting people to that is a challenge. But also, we haven't worked in an area where people actually get a lot of coaching in this. So I think about since I've become a consultant, I rarely get actual feedback from anybody unless I drag it out of them because we're working fairly independently. And unless I really push the nursing team leader, who's oftentimes the person that's kind of closest to me as a colleague because they're often more senior than me, they might be the one who's most likely to actually give me some feedback. There's still this power differential that exists that makes it really hard to get feedback. So it's bizarre that we don't actually have an ongoing kind of coaching culture around this, like you say. So there's probably some structural elements that allow people to perpetuate kind of problematic behavior because they're not actually getting regular feedback. I think back to an experience that I've had in my organization recently where on the phone I was told by a colleague that I was useless and some swear words were said. And I didn't feel like I could call that person back the next day and say, look, this was the impact of your behavior. Usually I'm pretty good at that. I don't mind ringing people up and saying, no, I don't know if you recognize that this was the impact of your behavior, but this is, what happened and how I was impacted by it. But in this particular situation, I actually felt a bit threatened and didn't feel like I could have that conversation on my own. So I sent it up the chain of people because I think it was really important. I said, look, I'm actually happy to be engaged in a conversation with this person that's mediated and provide some of that feedback. And unfortunately, it took over a month and a half with me persistently bringing this up for that person to even receive that feedback. And then what chance do they have to actually reflect on that and maybe change and shape their practice? So I actually kind of ended up feeling for this person at the end of the day because they ended up with this feedback in their inbox a month later and not actually a useful kind of coaching opportunity to reflect meaningfully on behavior and change and shape that in a way because I don't know what is wrong with our organizations that we can't make it happen. I don't understand.
Yeah, I mean, the phrase that I come to a lot in these moments is Brene Brown's, I'm not here to be right, I'm here to get it right. And somewhere we've lost that. And I get it. I think you also know Sheree Johnson in Australia. She talks a lot about the culture of medicine with perfectionism and competition and stoicism was the bedrock. And in that culture, especially once you reach the pyramid, the hierarchy, you reach the tippy top of being an attending or a consultant, then you no longer are susceptible to feedback. You can do no wrong. And I think that's the real issue that is.
But even in this situation, like you don't even get the feedback, even if you do want to improve. Like maybe this person actually doesn't want to make me to feel really terrible, but they didn't even get the opportunity to reflect on that performance. So I guess I try as much as I can to take some personal responsibility for that because it's easy to say, oh, this is an organizational problem, but people are the culture. It's like we are every single day shaping the culture and responsible for this kind of ongoing development of our values and beliefs and how that plays out and lives out in our organization. So there are some simple things that individuals, especially if we've got a little bit of power, can do. So if I overhear that a registrar comes up to me and says, somebody was just really rude on the phone to me, I usually just pick up the phone and call that person back and say, look, I have no idea what happened in the conversation. The impact is that now our resident is almost in tears. It's not about who's right or wrong, but however that conversation played out, this is the impact, and it might be worth you reflecting on that a little bit. Whether they do or not, I don't know, but I think we do actually have to take some responsibility for shaping the culture that we find ourselves in, because the way that we behave impacts only the 7 or 8 or 9 or 10 people that are around us, but that impact is important. And so I suppose empowering people to, there's a lot of learned helplessness in healthcare as well. You can't change anything, it's too big. And I feel that sometimes. But on my better days, I think, well, what's my role in shaping where I'm working and what's my responsibility to do so? But sometimes that gets a bit exhausting.
Totally. I think that is such a powerful place for us to end today's conversation as we move into some rapid questions is when I've talked about it on this podcast before, and I always say, like, please keep listening. Don't turn off yet. Because when people hear learned helplessness and healthcare workers, they're like, are you kidding me? The system is completely destroying us. It is, but you also have to realize we are the system.
What do you mean by the system?
Right. What do you mean by the system? And they're like, but the system. And it's like, it is people. And so if you can make just a little space for some active agency, that's what we all need to do.
Yeah, and one of the analogies that I've found most useful, maybe when I was in the darker depths of feeling that learned helplessness, is just reading a little bit more about healthcare as a complex adaptive system, and then looking to some other complex adaptive systems like the way that starlings fly and seeing how they navigate the complexity. And essentially it's very simple. They have birds that can fly, and then those birds pay attention to the 7 or 8 birds around them and adapt and move with them. And that's it. So, and that's all they have control over. And so I try when I show up to a shift to think, who are the kind of 8 to 10 people that I can influence, and how can I make that influence as kind of positive as possible in the hopes that that might kind of transfer. And so it's fairly limited when you think about it, right? I work in a healthcare organization that has, I think, 11,000 employees or something. So a limited impact on 10 people a shift is not much. It is actually what I can do. And I do that better or worse on some days, but it at least is something I think about when I walk through the doors.
I love that. And it's a really simple call of action for the listeners. Is does have to be this huge thing. Think a little bit smaller about your circle of influence on your next shift.
Exactly. Yeah.
So let's move into some rapid questions. What are you excited about this upcoming year?
I'm excited. I'm spending a little bit more time with emergency teams, thinking about how they identify, manage, and mitigate team stress. So we know a lot about individual level stress. So think of people telling you to do more box breathing at work, but we actually don't have a lot of research or understanding about how teams do this together. Yet, if you talk to anybody who practices emergency medicine, they just say a stressful shift is fine when I'm on with the right people. And so understanding how emergency teams do this, I think might give some insight to other industries about really how teams regulate and identify the stresses that they're facing. So I think diving into that with teams will be a bit of fun.
And if our listeners want to connect with you, how do they reach out to you?
I suppose they could connect with me on Twitter, or my email is also on my website, which is evepurdy.info. And either one of those ways would be fine. I am on LinkedIn, but I'm not as good at checking that on the regular.
Yeah. And then tell our listeners about if they are thinking about checking out a healthcare simulation or technology conference in Australia, what would you recommend?
Oh, you got to come to Sim Reconnect 2024. It's in November on the beautiful Gold Coast. And it is a nice conference that brings the simulation community together in Australia for a day of fun at Bond University.
Oh, that sounds amazing. Is it every year in the same location?
This will be the 3rd year. Yeah. So come to 2024, because who knows if there'll be a 2025.
That's right. Live for today. Amazing. Well, thank you so much, Eve, for generously sharing your time and expertise with our audience.
Excellent. Thanks for having me, Andrea.
Thanks for listening to Heartline, conversations with healthcare changemakers following their heartlines. I'd so appreciate it if you could take a quick moment and hit the like button and also the subscribe button that you'll find within your podcast app or platform that you're listening on. It also really helps if you can leave a review. I would certainly appreciate a 5-star review and a few comments about what you liked about this podcast. Don't forget, you can also forward this to people in your network. People love getting new podcasts and changing up what they're listening to. So sending a podcast to a friend or colleague, or even to start a conversation about a change that needs to happen in your organization, is a great way to be a change maker. This podcast represents the views of the host and guests. It does not represent the views of any entity we work for or with. It is also for informational use only and does not replace any professional advice, including medical or psychological. If you are interested in unlocking your true potential, reach out to me. If you're an organization interested in supporting the well-being of your people, I'd love to connect on innovative solutions. Schedule a strategy session at andreaaustinmd.com. Sound editing services are provided by Better Podcasting Services, and you can find their website at betterpodcastingservices.com. And I'd also like to thank our future Dr. Caitlin Din, who is the production assistant for this podcast.